the candidates for the Mrcp cases. So today I have come with yet another case for the Mrcp cases, and today I'm going to talk a bit about Huntington disease or a case of chorea which you may came across in your neurology station. Okay, so let's move on. So here's your scenario. Mr. John Smith is a 66-year-old retired accountant who presents to the neurology clinic accompanied by his wife. Mrs. Smith reports that over the past several months, she has noticed her husband experiencing involuntary, irregular, and jerky movements affecting his face, arms, and legs. Okay, so he is a 66-year-old, and this is your scenario. So, because this is a neurology station, so you're not allowed to take any history. You'll just have some information, and then you're going to proceed with the examination of the patient. You have some time before you enter the station, so in the meantime, you can think about all the differential diagnoses and structure your examination approach. Involuntary, irregular, jerky movements affecting the face, arms, and legs. So it can be chorea, it can be cerebellar symptoms. So keep your mind open once you enter the station. So once you enter the station, you will obviously going to greet the examiner and greet the patient. You'll ask the consent and then you'll proceed with your examination. In this case, as the patient has presented with involuntary movement, so you start with the inspection of the patient and you want to look for any choreiform movements. So these are involuntary, dance-like, irregular and jerky movements affecting the face, limbs and trunks. And these movements, important thing is they are random and purposeless. And this is the main differentiating points from the chorea from other cerebellar symptoms. You will also look for the dyskinesias. So assess for any involuntary movements that may include dystonias. Dystonias are actually sustained muscle contraction and causing twisting or repetitive movements. And other main differential is athetosis, which are slow breathing movements. You want to look for any motor impairments. So check the power, look for any signs of muscle weakness. Particularly, we can expect some muscle weakness if there is an advanced stage of the disease, and which may manifest as we may found decreased muscle bulk and strength. Cognitive examination is important. However, you have a very short time in the neurology station, but it's worthwhile remembering it and mentioning to the patient once you are doing your presentation that I like to do the cognitive examination of the patients. So you want to assess for any impairments in various cognitive domains like memory, executive function, attention, and visuospatial skills. And you can do the mental status examination. So this will give you some idea if you can do the mini mental state examination. This is actually cognitive screening which you can do. And the other option is Montreal Cognitive Assessment. Psychiatric examination is also important. Here you're looking for mainly any behavioral changes. So we observe for any psychiatric symptoms including irritability, mood swings, depression, anxiety. And obviously for the psychiatric assessment, we want to evaluate the patient mood, affect, thought, any content. Then the important neurological signs, look for any gait abnormalities. So assess the patient gait for signs of any unsteadiness or imbalance or gait apraxia. Check for the reflexes. Normally we expect to find hyperreflexia, particularly in the lower extremities, and this can be present in the Huntington disease. Eye movements, very important. Look for any saccadic eye movements which may be impaired in advanced stages, leading to difficulty in smooth pursuit and saccadic initiation. I put the diagnosis here at Huntington disease, but obviously in the examination you will give the diagnosis of Huntington disease, but you will also talk about the different differential diagnosis once you've diagnosed the chorea. Because Huntington disease, we can diagnose by having a family history, and we also need a more detailed history about the patient before we come across a diagnosis like Huntington disease, and obviously it needs a lot of tests and genetic testing. So if we're talking about the Huntington disease, then the positive findings on examinations which we'll be looking for is choreiform movements, which I already explained. These are irregular jerky movements which affect the face, limbs, and trunk. We expect to have some cognitive impairments, so maybe some defective memory, executive function, maybe attention and visuospatial skills. Behavioral changes, which includes mood swings, irritability, depression, anxiety, and apathy. Gait abnormalities, so unsteadiness, imbalance, gait apraxia, and finally hyperreflexia. Increased deep tendon reflexes, particularly in the lower extremities. I put few additional points here because now you know this MRCP basis, we have got a consultation station as well. So in the consultation station, any case can appear, like neurology, maybe from cardiology, maybe from the GIT examination. So one should be aware and should prepare for both. This case can present in the neurology station. It can present in the consultation station as well. So these are important that you should know about the history, detailed examination, because consultation station you have more time, maybe you can do the mini mental state examination also, and we'll take a detailed history as well. So let's talk about the differential diagnosis in this patient. So the positive findings which you find is the patient has some jerky movements which are purposeless, and we're thinking about chorea. Other genetic movement disorders like spinocerebellar ataxia, and these are the group of inherited neurodegenerative disorders, and there are progressive cerebellar ataxia. But some subtypes can also present with choreiform movements. You put the differential diagnosis here. Obviously, you're not allowed to take history. You don't know whether the ataxia is progressive or not. Other differential which you can put in the movement disorders or in chorea is Wilson's disease. And we all know that this is an autosomal recessive disorder, and normally we have some copper accumulation, and which leads to hepatic dysfunctions, and there can be neurological manifestations as well, like movement disorders as well as some psychiatric symptoms. If you can remember this, it's okay. If you don't remember, still is fine. This is something called dentatorubral pallidoluysian atrophy, and this is a quite rare genetic disorder and can present with some choreiform movements, ataxia, and cognitive decline, as well as some psychiatric symptoms. So it somehow resembles the Huntington disease. DRPLA. If you remember it, it's okay. Otherwise, put the other differentials like spinocerebellar ataxia and Wilson's disease. So this is, we have talked about the genetic movement disorders. In your differential diagnosis, we can talk about the acquired movement disorders as well, like Sydenham's chorea, which is a post-streptococcal autoimmune disorder and is characterized by choreiform movements. And these typically occurs in children and adolescents following a streptococcal infection. Drug-induced dyskinesias, remember certain medications that the patient is on some antipsychotics or any dopamine receptor blocking agents, they can also lead to choreiform movements and other extrapyramidal symptoms. Continuing with our differential diagnosis, we will put other neurodegenerative disorders also in the differential diagnosis, like Parkinson's disease. While Parkinson's disease, it typically presents with bradykinesia, rigidity, and resting tremor. Some atypical form can manifest with some choreiform movements. Another differential which is worth considering in the neurodegenerative disorder is frontotemporal dementia. This is a group of neurodegenerative disorders, and they are characterized by decline in behavior, language, and executive functions, and this can overlap with the psychiatric symptoms which are seen in the Huntington's disease. Alzheimer's disease, well, you can put in the differential diagnosis of neurodegenerative disorders, But you know that Alzheimer's disease is probably is most likely a memory impairment, and there is a cognitive decline. But behavior and psychiatric symptoms, these can also occur mimicking the Huntington's disease. Other differential diagnoses which we can consider in case of movement disorders include metabolic and toxic causes like hyperthyroidism. So, as you know that hyperthyroidism can present with some tremors, hyperkinesia, and psychiatric symptoms. So these can also mimic the Huntington's disease. Other metabolic disorders like hepatic encephalopathy, uremia, and electrolyte disturbances, these can lead to movement disorders and cognitive impairment. And don't forget toxic encephalopathies, exposure to certain toxins like carbon monoxide or heavy metals. These can also cause neurological symptoms, including some coriform movements and cognitive dysfunction. Psychiatric disorders like bipolar disorders, these can also present with some mood swings. So it comes in the differentials with irritability and psychiatric symptoms. They are similar to which are seen in the Huntington's disease. Schizophrenia, it can present with hallucinations, delusions, and disorganized behavior. And some of these psychiatric symptoms again overlap in Huntington's disease. Finally, in the differentials, I put some infectious causes like neurosyphilis, which is late-stage neurosyphilis, can present with a wide range of neurological and psychiatric symptoms, including movement disorders and cognitive decline. And finally, Creutzfeldt-Jakob disease, which is a rapidly progressive brain disease and is characterized by dementia, myoclonus, and other neurological symptoms. So as you can see, I have put a lot of differential diagnoses here. If you can remember 4 or 5 should be enough. Whenever you do the differential diagnosis, try to divide them in different groups, and then you will remember it very easily. So here you can see that I have put different groups here. Other genetic movement disorders, this is the first group, okay, and in this spinocerebellar ataxia, Wilson's disease, and I have talked about the rarer one, dentatorubral pallidoluysian atrophy. Another group is acquired movement disorders, in which we have put sydenham and drug-induced dyskinesias. We have talked about the neurodegenerative disorders, in which we have put Parkinson's disease and frontotemporal dementia, as well as Alzheimer's disease. Metabolic and toxic causes, we have talked about hyperthyroidism and also talked about other metabolic disorders like hepatic encephalopathy, uremia, toxic encephalopathies like carbon monoxide or heavy metals. Psychiatric disorders, we have talked about bipolar disorder and schizophrenia, and finally infectious causes like neurosyphilis and Creutzfeldt-Jakob disease. Okay, so this is my differential diagnosis in this case. So how you will assess the patient further? So obviously we want to take a detailed history. If it comes during the consultation, obviously you want like to take a detailed history. So we want more information about the medical history, about any family history, neurological disorders, and psychiatric conditions. And neurological examination, I have already discussed in detail. So we would like to perform a comprehensive neurological examination to assess the motor, cognitive, and psychiatric symptoms. And psychiatric evaluation is also important, and to evaluate the mood, behavior, and cognitive function. So this was all about the history. Then how to diagnose the patients? We can do some imaging studies as well. So brain imaging, consider brain imaging studies like MRI to assess the structural changes in the brain. So in Huntington disease, if we are talking particularly, so MRI may reveal some characteristic findings like cortical atrophy, particularly in the striatum, chordate nucleus and putamen, and there may be enlargement of the lateral ventricles. Functional imaging like PET scan or SPECT scan, these can also assess the regional cerebral metabolism and neurotransmitter functions. So it provides some additional information about get some additional diagnostic information. Now, in any case, with where you see some neurological deficits or movement disorders, imaging studies are worthwhile doing, because here we want to exclude the other causes as well, like maybe it can be because of the some malignancy, some tumor there, maybe it can be because of the raised intracranial pressure. So all these things we have to rule out. And in the meantime, there are some specific imaging studies, like in Huntington disease, we may have a cortical atrophy in the striatum, and then you combine all these things with the patient history and the patient examination, and then you can have some idea that, okay, this patient may be having the Huntington disease. Genetic testing, well, genetic counseling, offer the genetic counseling to the patient and family members to discuss the implication of genetic testing, and we want to know about the inheritance pattern and family planning options. And genetic testing, we perform the DNA analysis to detect the expansion of the CAG repeats in the Huntington gene. And this is the hallmark, molecular hallmark of Huntington disease. A CAG repeat length above a certain threshold, usually 36 repeats or more, it confirms the diagnosis of Huntington disease. So this is about the genetics of the Huntington disease. In the laboratory investigations, we want to do the routine blood tests to assess for any metabolic abnormalities, and we want to rule out any potential causes of symptoms like thyroid dysfunctions or vitamin deficiencies. And genetic testing for differential diagnosis is also important, like other hereditary neurodegenerative disorders which have an overlapping clinical features like spinocerebellar ataxia or other trinucleotide repeat expansion disorders. Psychological and functional assessment, while we have talked about it, I just want to repeat a bit more. Neuropsychological testing, so consider the neuropsychological assessment to evaluate the cognitive functions, including the memory, executive functions, attention, visuospatial skills, and functional assessment, which assess the patient functional status and quality of life, including the activities of daily living, mobility, and social function. Family screening is important, so offer genetic testing and counseling to at-risk family members to identify individuals who may carry the HTT gene mutations and which may benefit from early intervention and surveillance. Considering the treatment of the Huntington disease, always remember that whenever you came across these type of cases, always involves the multidisciplinary team approach. So here the patient prominent symptoms are chorea, so we can have some pharmacological interventions to reduce the choreiform movements. So dopamine depleting agents, remember this, tetrabenazine or dopamine receptor blocking drugs like neuroleptics, which includes haloperidol. These are indicated and can be given for the symptoms of chorea. However, remember that caution is needed due to risk of worsening cognition and psychiatric symptoms. If the patient has some psychiatric symptoms, we then want to treat the depression and anxiety, immobility, and psychosis with appropriate psychotropic medications, including SSRI, atypical antipsychotics, and mood stabilizers. Patient will have some cognitive impairment, so we want to provide the supportive measures and cognitive rehabilitation. Patient may have a dysphagia, so we manage the dysphagia with the dietary modification, swallowing therapy, and possible enteral feeding. If necessary, to prevent complications like malnutrition and aspiration pneumonia. So these are the complications which can happen with the Huntington disease. Rehabilitative interventions are important in this case, as will be in any chronic case with neurological symptoms, signs. Physical therapy, implement a tailored exercise program. We want to address the motor impairments, improve the balance and mobility, and prevent the contractures and falls. Occupational therapy do have a role, so which assist patient in adapting their environment and daily activities. Speech and language therapy provides strategies to address the communications and difficulties and solving problems associated with dysarthria, dysphagia. Psychological support, we already talked about it, offer counseling and support service to help patient and not only the patient, their families as well, to cope with this emotional and psychological impact of the disease. Genetic counseling and family support. Well, genetic counseling can we provide genetic counseling to affected individuals and their families, and we want to discuss the inheritance pattern, genetic testing, family planning options, and psychological implications of Huntington disease. Family support groups, we can ask patient to we facilitate the access to the support groups and community resources for patient and families to connect with others who are facing similar challenges. Advanced care planning is important, as is important in any chronic conditions. So end of life care, we initiate discussion about advanced care planning, including preference for the end of life care, resuscitation status, and palliative care options. Research and clinical trials. Well, experimental therapies consider enrollment in the clinical trials and research studies, investigating novel therapeutic approaches for Huntington disease. Regular monitoring and follow-up. So MDT, remember this word MDT, it will come again and again. So coordinate regular follow-up visits with a multidisciplinary team, and we have, which comprises of neurologist, psychiatrist, rehabilitation specialist, and allied health professional to monitor the disease progression. We want to adjust the treatment strategies and address the evolving needs over time. So this is about the briefly about the Huntington disease, or a patient who has come with a chorea. And then remember that your approach should be to pick up the findings, and once you have picked up the positive findings, think about all about the differential diagnosis, and then you can prioritize your differential diagnosis and come across in Mrcp cases at least 4 or 5 differentials, because the examiner will maybe ask you more about that. And make sure you, once you give the differentials, you know something about that differentials, because the examiner will pick up from there and will like to know more about your differentials. Finally, I put some questions which can be asked in your PACE examination. So examiner may ask, what are the characteristic motor features in Huntington disease? We already discussed it. So it includes some choreiform movements, and these are irregular, involuntary dance-like movements affecting the face, limbs, and trunk. And these movements can be exacerbated by stress and voluntary movements. Another question which is quite common is, how will you differentiate between chorea and other type of abnormal movements? So remember that chorea is irregular, involuntary, unpredictable movements that flow randomly across from one part to another. So it can be distinguished from other abnormal movements like dystonia. Dystonias are sustained muscle contractions, so causing twisting or repetitive movements. And athetosis, these are slow breathing movements. Okay. Examiner may ask, what are the genetic implications of Huntington disease? We already discussed it, just we repeat it. So it is an autosomal dominant genetic disorders, and there is an expansion of CAG repeats in Huntington disease and Huntington gene on chromosome 4. So offspring of affected individuals, they have a 50% chance of inheriting the mutated gene, and genetic testing can confirm the diagnosis, and they provide the predictive testing for at-risk family members. Another question which is quite commonly asked, how would you approach the management of choreiform movements in this patient? So the management of choreiform movements in Huntington disease includes pharmacological interventions to reduce the involuntary movements, tetrabenazine, which is a dopamine depleting agent, is commonly used to alleviate chorea. However, caution is needed due to risk of worsening cognitive and psychiatric symptoms. Other options, we have dopamine receptor blocking drugs such as neuroleptics, although they also have a serious adverse effects. In terms of the prognostic implications of Huntington disease, examiner may ask. So remember that the Huntington disease is a progressive neurodegenerative disorder, and it has a variable clinical course. So it can vary actually. The disease progression and severity of symptoms, this can vary among affected individuals. If we talk about average life expectancy after symptom onset, is around 15 to 20 years. So the disease ultimately leads to significant disability, and there's a loss of functional independence with complications such as dysphagia, aspiration pneumonias, and cognitive declining, which is contributing to morbidity and mortality. Ethical considerations involved in genetic testing for Huntington disease. This is a very common question. So genetic testing, remember, it raises several ethical considerations, including there are issues related to autonomy, informed consent, confidentiality, and the psychological impact of the testing results on the patient and family members. So pre-test counseling is essential to ensure that individual understands the implication of genetic testing, including the potential for either we can have a positive result or negative result, as well as the availability of the support services and family planning options. So finally, how do you support the psychological well-being of a patient which is diagnosed with Huntington disease and their family members? So supporting the psychological well-being of patient and family is effective. This involves mainly counseling, education, and access to support services. Now, this may include individuals or family therapy, support groups, and resources for coping with the emotional and practical challenges of living with this progressive neurodegenerative disorder. So, it's important to address the feelings of grief, anxiety, and depression, and caregiver burden, and to promote the resilience and adopting coping strategies. So this, my dear doctors, this is all about Huntington disease. Hopefully I have covered almost everything, and I will see you in my next presentation.